All right, our next speaker is my co-associate program director, Grace Mandigo, who for some reason has adopted a pain population to treat. I imagine because it takes about a year to get an appointment with a headache neurologist. So we are here to learn about endovascular treatment of migraine headaches.
I'm Grace Mandigo, and today I'm going to talk to you about treatment of headaches. Maybe I'll just do that. Okay, there's my disclosure. So middle meningeal artery embolization is something we've been doing for a long time in the endovascular community. We've been doing this ever since I can remember for treatment or embolization of tumors, embolization of fistulas, and more recently, embolization of subdural hematomas. The technique varies widely. There's many ways to skin this cat, and I'm not going to talk specifically about that except to say that it seems that a lot of different techniques work. So we started doing subdural embolization, I think, at our institution around 2018. And a couple years into that, we had a fellow who some of you may know. His name is Jonathan Sisti, who brought this paper to my attention, which was published in 2020 in the New England Journal of Medicine. And it was a review article on migraine headaches. And what caught his attention was this picture here, which was the pathway for, or illustrating the pathway for the pain perception in migraine headaches. So it started with this blow up here shows you the middle meningeal artery and the afferents innervating the middle meningeal artery. I don't know if you can still hear me when I turn around like that. Let me do this. And since we were doing so many of these subdurals for chronic, MMA embos for chronic subdurals, he pointed out that there is a role for middle meningeal artery somewhere in this migraine pathway, and can we manipulate this to get control of migraine headaches? So briefly, this is where this trigeminal vascular system is stimulated, and then the signal goes to the trigeminal ganglion, brainstem, thalamus, cortex. And then this is a blow-up of the smooth muscle cell in the artery wall. So the whole system is activated by the release of these vasoactive peptides, one of which is CGRP, and some of you may recognize that as a target of some of the more recent migraine medications. And that binds to its receptor and results in an intracellular cascade that ultimately leads to smooth muscle cell relaxation and vasodilation. And it's the vasodilation of this artery that then triggers this whole system, broadly. So we thought a good place to start would be to start a subdural database. Let's just start collecting all the information about the patients that we're doing MMA embolizations for in the context of subdural hematoma. And let's see if any of them have headaches. And actually, Nadine is here. She did all this work recently. She combed the database. There were just over 100 patients from 2018 to 2023 who had MMA embolizations, and she identified 11 patients who had migraines prior to their subdural embolization, and then tracked what happened to them after the embolization. And it turns out one of the patients had a bunch of other things, a Chiari, a shunt malfunction, hydrocephalus. We took that patient out. We were left with 10 patients, and 40% had complete resolution of their migraine headaches after the MMA embolization. 50% had improvement, and 1 person had no change. And then she pulled out other patients who had chronic headaches prior to the subdural embolization, added them to the migraines, and we had 20 in total out of the cohort. One of them died in the hospital due to medical complications. The other one is the Chiari patient I just told you about. And of the remaining 18, it's about the same level of improvement in that only 11% had no improvement. Turns out, of those 2 patients, one of them didn't get a bilateral MMA embolization because the one side was an ophthalmic origin MMA, so it was only half the head. And the other patient, because of the tortuosity of the frontal branches, only got the posterior branches embolized. So the other thing we thought would be, so a lot of people had the same idea. It really wasn't just us. A lot of people were making the same observation in the subdural patients that they were treating, that people who had headaches seemed to be getting better. Their headaches seemed to be getting better after the subdural embolization. And this is a paper from the Barrow group, which illustrates basically the same ratios. They had a similar number of patients, a number of percentage of patients that had pre-embolization headaches, and their outcomes were similar in that about 10%, 11% did not improve, but everybody else had either resolution or improvement of their chronic headaches. Now, subdural is a huge confounder in the context of headaches, and all of this is very retrospective data. but it was a starting point. And at the same time, we also decided to just kind of get a grip on what exists in the literature right now. What do we know about middle meningeal artery embolization or manipulation in the context of headaches? And so we compiled a list of the sort of the state of the union at the time. Now, since then, there have been other publications, and there seems to be some energy behind trying to figure out what happens in MMA embolization in the context of headaches. So I'm going to talk to you guys about just the papers that address this question of endovascular manipulation or treatment of the middle meningeal artery and in the context of headaches that do not have anything to do with subdural hematomas. So starting in 2014, this is a group of 2 patients who underwent middle meningeal artery lidocaine infusion for acute headaches. So not migraines at all, but 2 patients that had ICH, and they had pain due to the ICH, so they got lidocaine and methylprednisolone infusion into the ipsilateral MMA only, and this is the result. So here's the pain scale that everybody's familiar with, and these are the 2 patients. They had bad pre-embolization pain. It got somewhat better, and then it got worse, and then it seems that at about 24 hours they had some improvement, although it's a little bit all over the place. Fast forward to 2021, the next publication we have that looks at the MMA and endovascular treatment thereof in the context of headaches is again from the same principal author, Qureshi, and his group, who have now 4 patients who presented with acute headaches, 2 of which who had a prior headache syndrome or prior diagnosis of migraines and then came in with an exacerbation in terms in the ER with status migrainosus. And then the other 2 patients did not have a headache syndrome prior to their presentation, but came in with acute headaches, subarach in one case, and just headache out of the blue in the other case. The 2 patients who did not have chronic headaches are here, and both patients had complete resolution of their headache pain after the lidocaine. That is illustrated here. So preoperatively, they had very bad pain scale ratings. And then on the day of the embolization, they both had complete resolution of the pain, which was durable to post-op day 1. And then the pain came back on post-op day 2 to a lesser level, which then increased on post-op day 3 and then stayed sort of at that level for a few days. A high level, albeit not at the same level as pre-op. The next 2 patients were people with migraines who came in with status migrainosus. They both also had improvement in their pain scale post-operatively, and then they followed these patients to 3 months because they did have this chronic headache syndrome as well. And they found that there was some improvement in their disability score. The MIDAS is a disability headache score at 3 months, albeit not incredibly clinically significant for one of those patients. He still had a very severe headache disability score. And then in addition, they found that the VAS score, the pain scale, really wasn't that different from their baseline at 3 months. So not an incredibly durable effect. But post-operatively, at least in the context of acute headaches, it seemed to make a difference. And then in 2025, the same principal author and his group published a series of 7 patients who presented also with acute headaches, this time in the context of subarachnoid hemorrhage. And they were treated with bilateral middle meningeal artery lidocaine at varying doses. And the outcome measures that they reported on were the VAS pain scale as well as angiographic imaging. So basically everyone got better, some people immediately, some people later, some people one side, some people both sides. And the interesting thing about this was that they published the pre and post angiogram. I don't know if that's coming out well, but this is prior to the lidocaine injection, and this is afterwards. And you can see that the arteries are open here. This is a normal-looking middle meningeal lateral angiogram, and this is after the lidocaine goes in. And they concluded that the mechanism probably has something to do with vasoconstriction because the vessels are so much smaller here, and some of them you don't even see at all. In the literature, if you look at lidocaine and what it does to arteries, you'll find that sometimes it vasodilates and sometimes it vasoconstricts. And I'm not exactly sure when it vasodilates and when it vasoconstricts, but they're arguing that vasoconstriction is at least part of the equation or part of the mechanism here. The other thing that Qureshi pointed out or hypothesized as a mechanism was that there is an artery that goes to the trigeminal ganglion down at the base of the MMA, and he thought that potentially the lidocaine was bathing the trigeminal ganglion and potentially resetting it or desensitizing it or doing something that could account for why there is a longer-term effect on the pain than you would expect for lidocaine, because lidocaine washes out right away, and the half-life, it's gone in a couple hours. Why are we having an analgesic effect out to at least a couple of days? And that was a hypothesis at the time. Now, I don't agree. I don't think that a catheter here with an injection here is going to do anything to an artery down at the base. And I know that for myself, at least, when I do these embolizations, my catheter is even much further out, and I'm nowhere near this small artery that goes to the trigeminal ganglion. So I think it's probably something different. And in looking at these pictures, I would argue that this kind of looks like an embolization. So potentially, is there something going on with the lidocaine, the dose of the lidocaine going into these branches that are actually occluding the branches and causing sclerosis and potentially something similar to an embolization? This is another paper from a different group, actually two groups, that, and this is 2025. This is the first time we're looking now at chronic headaches. So every paper up until now, every publication was lidocaine in the context of acute headaches, and this is the first one that addresses the role of MMA lidocaine in the context of migraines. So in two centers, they had 45 patients that underwent 50 milligrams of lidocaine on both sides, and they found that a little bit less than 2/3 of patients had immediate relief of pain. So it's not quite as remarkable as the 100% relief that we're seeing from the other papers, but still a good number of patients are having immediate relief from the lidocaine injection. And then they followed these patients to 1, 2, and 3 months, and they found that the pain relief was less so as time went on, which you can kind of expect. And then at 3 months, only really a quarter of patients are reporting pain relief. They also did a HIT score, which is what this is. It's a questionnaire that measures the impact that the headache is having on your life in terms of pain and activities and your ability to do things. And the score ranges from 36 to 78. The HIT score at baseline was 69, which is a severe impact. And at 1 month, the patients had a significant drop in their headache impact score, but this is still a severe headache. So there was a statistically significant, measurable effect on headache impact score, and that was not durable to 2 months or 3 months. This is a small case series from 2025, published in March, that I could not search or find on PubMed, but I did find this on Google, and I think it's worth mentioning. So these are 3 patients, and the first that I could find who reported in the literature, I guess, who underwent actual embolization for their migraines. So prior to now, it was lidocaine, and now we're seeing actual embolization of the middle meningeal artery in this context. And this paper reports that all 3 patients had improvement in their HIT score, so the headache impact, and in their disability score, which is illustrated here, immediately. And then they actually continued to improve at 1 month and 3 months. So they had an even greater drop in their HIT and their disability at 1 month, and an even greater drop, almost to completely normal, at 3 months. So in comparison to the lidocaine data, where the effect was really not durable out to 3 months, potentially this is a treatment that not only is durable, but can improve over time. And then finally, this is a paper that was published over the summer from Brazil, where 10 patients who had intractable migraine headaches underwent MMA-EMBO. But the part of the selection process was they gave lidocaine in the MMA to both sides in patients, and only if you had a response to the lidocaine did you then qualify for the embolization. So they had 10 patients that met all the inclusion criteria, and they embolized, in this case, with NBCA glue to both sides, and they found that patients had, this is their baseline VAS score, right? So they had a very bad pain level at baseline, and it actually got worse post-operatively, and then after a few hours got better, and then finally the next day was significantly a lot better than they presented with. And then they also presented long-term data, and this is also HIT score. The baseline is very bad, and then at 1 month, the patients had a remarkable drop in their HIT score. And remember, the best you can do is like a 36, I think. So 40 is very, very good. And that was durable up to the 6-month time point as well. So I just want to present to you some of the patients that I have embolized myself for headaches. This patient is a 42-year-old woman who's had a long history of headaches, and she was going to have an angiogram anyway because she had an aneurysm. And I offered she was crying in my office because she was in so much pain. So I offered to her an MMA-EMBO, and she had that done, and this is her 2-month kind of post-op clinical status. This is just a pre and post of one of the branches of the middle meningeal artery. I do mine with PVA. So here's the angiogram, and then post embolization, there's the contrast. It's shut down. So prior to her embolization, she was having 12 headache days out of 30 that were severe. She was really having headaches on all days, but 12 that were severe. And then postoperatively, that dropped to 3. Preoperatively, her pain score was 8 to 10, postoperatively 3. She had these associated symptoms with her headaches. People with migraines generally do. Phonophobia, lacrimation, nausea, and she didn't have any of that after her surgery. Interestingly, she was really opposed to taking medications, and so while she did have to medicate with these medications, she was also smoking marijuana 10 days out of the month to help her with her pain control, and she told me at her 2-month post-op she has not touched marijuana since, which is really great for her aneurysm because smoking it was not helping. She also reported to me that one of her big triggers for migraines was loud noise, and she was a person who really enjoyed going to live music concerts, and she was unable to do that because it would 100% of the time trigger a really bad migraine that would last for days, and she has since been able to go to a rock concert without any headache. This is the next patient, who is a 52-year-old woman also who had an angiogram due to workup of an aneurysm, and she was also crying in my office that she was having such horrible headaches. And so I did her MMA embo as well. Now, she had 20 out of 30-day headaches, and that reduced. It's a significant reduction, but maybe not as good as I would have liked, to 8 out of 30. She started with 10 out of 10. Pain scale, and that dropped to 5 out of 10. She had all these symptoms before her procedure, and then interestingly, she went through a number of different permutations of other migraine symptoms that she didn't have before, almost like the procedure triggered other types of migraines. Her headache pain went down progressively over the next week until she really didn't have any of these symptoms anymore. It's like her migraines just sort of settled to this lesser level. She's very happy with the result, but I really feel like we could have done better. And I'll tell you the reason I think that she didn't do as well as I would have liked is because I was trying to minimize this treatment. I was trying to just do the angiogram the way I normally do angiograms. I went radial. I shouldn't have. She had a very non-bovine arch and very straight arteries, so I didn't get the stability I wanted. And I had to leave one of these arteries unembolized, and this is the left side frontal division. I was unable to embolize that because every time I did, the whole system would fall out into the aorta. And so lesson learned from that, I feel like right now I send everybody for CT angios of their chest so I can look at their arch before making a decision on approach. And then finally, this is a patient who was 43. She had a history of migraines, which after having a COVID infection became severe. And she had tried every single medication you can think of, and she was on year-round Botox, still without very good control. She came to me with a PCA aneurysm, which I embolized. And then on her follow-up angiogram, I offered to her a middle meningeal artery embolization, which she was excited to try. And after that, she went from having headaches every day to having them 4 out of 30 days. Her pain scale was 8. Afterwards, her most recent, this is a 4-month post-op, her most recent headache neurology documentation is a 0.5 out of 10. She had all of the symptoms, including she was bedbound for a significant amount of days per week, missing work and things like that. She hasn't had to do that any longer, and she was advised by her headache neurologist to continue all of her medications, which I think is smart, in the postoperative period, but at this point she is asking to start to wean off of some of those because sometimes they make her feel sick, and she's in the process of doing that now. She hasn't had Botox since the treatment. And this is a testimonial from her. She says, she sent this to our office, "I've been suffering from chronic headaches for years, and every single day felt like a struggle. I tried everything, daily prescription medications, lifestyle changes, even Botox injections. While some treatments helped temporarily, nothing gave me lasting relief. That all changed when I underwent this procedure. For the first time in years, I woke up without a headache. It's been truly life-changing. I can concentrate at work, sleep soundly, and finally enjoy life without the constant cloud of pain hanging over me. I'm so thankful to the team for giving me my life back." And that's all right. There are some clinical trials that are underway, right? And they are not randomized. They are not controlled. They're really single-arm studies, and there were 3 of them that I could find. So the first one is from China. It's done enrolling. In this particular study, they're examining the safety and efficacy of coiling the middle meningeal artery for chronic migraines. Another trial, which comes out of Northwell, is going to enroll patients in a single-arm study where they're going to inject lidocaine on both sides for headache control, migraine control, and then a multi-center study sponsored by Sarah Nova's using only glue is going to look at embolization, glue embolization for control of migraines. This is the team without which none of this would happen. Everybody here has contributed clinically to the care of these patients or academically to writing papers and analyzing the data. And I'll take any questions. Yanking on it.
Hi, Thomas Krivik. I'm actually a neurologist at Holy Name. So really exciting data, actually, looking at especially people who are very refractory. And we definitely all, as neurologists, have a lot of patients who have this type of difficulty. I guess one question I had was, has anyone also looked at things like the trigeminal autonomic cephalogias, which tend to be even more refractory, like cluster headaches specifically, would be one of the things that I would think about as...
Yeah, Alex Ramos, one of our colleagues, actually just told me recently that he had a patient with a subdural that he embolized with cluster headaches. I believe, I'm sure it was cluster headaches, and he said remarkably the patient no longer has headaches.
Wow.
So I do think there's a potential role there too.
Okay. I will be talking to Eleanor a little bit about this more.
Absolutely.
Thank you.
You're welcome.
I mean, they don't cry in my office, but a lot of, I don't know why, but a lot of acoustic patients have bad headaches in the retromastoid, retroauricular area. For
which patients?
Acoustic neuroma patients.
Acoustic neuroma patients, yeah.
IAC drilling probably does it because MVD patients almost never get it, but people who have acoustics done through the retromastoid approach, most of them have headaches, and in some it lasts for years. Is it? And we say it's from irritation of the dura, basically. I mean, is it feasible to embolize that part of the dura?
I don't see why not. It's such a minimal procedure. It's really not a whole lot more than an angiogram. It's maybe not the place to start, but I will tell you that it seems to work in subarach, ICH, headaches that come out of the blue, non-migraine headaches, now migraines. It makes the most logical sense in migraines, I think, to start there, but I really think there's going to be a broad application here, so it's possible.
And in any case, I'm going to have somebody to send them to now.
Absolutely. For sure, yeah. I think, yeah, I don't think the trigeminal, I mean, like, it certainly there's a role here, right? But intracranial vessels in general, like, I can trigger a migraine by injecting verapamil into the ICA, right? So it's sort of like my reading, and I'm not a headache scientist or neurologist, is that it's not just the MMA, right? There are a lot of things, a lot of arteries that can trigger a migraine, but this is the one we can take, right? That's accessible and that we have a lot of experience taking, and nobody cares if they have a middle meningeal artery or not. And it's a gamble. It certainly was a gamble to say, okay, if we take this, are the headaches gonna go away? But it looks like at least for the people that I've seen and for these small case reports, which are entirely biased and retrospective right now, that there's a lot of potential here to making a difference. So yeah, you're right. There are definitely other triggers. And really, even when we do the MMA embos, not shutting down the entire dura, right? Because the posterior meningeal and the falcine and everything else, there's a lot of still vascularity there. So I don't know what the threshold is or how much you have to take down in order to get relief, but I will tell you, if I do a unilateral MMA embo, I generally, I don't think that works.